Good afternoon, everybody. I'm very glad to be here with you, and in the next hour, I would like to share with you my point of view in the treatment of gingival recession and in the treatment of soft tissue dehiscences around implants. When we speak about gingival recession, soft tissue dehiscences, our first thought is regarding the use of connective tissue graft. Connective tissue graft harvested from the palate is the best material we can have because it's already mature, it's already stable, and if harvested with the desepithelialized free gingival graft technique, it is able not only to increase the thickness of the soft tissue immediately after the surgery, but the connective tissue is able also to increase the thickness with time. And once harvested, it's very easy to handle. But on the other side, harvesting the connective tissue graft from the palate means two surgical area for our patient. So that means increase the morbidity for the patient, the length of the surgery, and especially in the treatment of multiple gingival recession, if we need to have connective tissue to more than one recession, we need to harvest a lot of palate, a lot of tissue, and that means that for the patient, the post-op will be painful. And obviously, harvesting connective tissue graft from the palate is time-consuming and is also a technique that requires a surgical skill for the surgeon. So what we would like to do is to reduce as much as possible the need for connective tissue graft harvesting. And at the beginning of the bilaminar technique, the dimension of the connective tissue that was needed for this technique was very big in all dimensions, width, height, and thickness. And I demonstrated with my research group in Bologna that it is possible to reduce the dimension of the connective tissue graft in order to reduce the discomfort for our patient, but obtaining at the same time, the same result in terms of complete root coverage for our patient. But this is not enough. What we would like to obtain in the future and what we are now studying in some research protocol is the possibility to use a connective tissue substitute that will be able to ensure the possibility to obtain complete root coverage, good aesthetic result for our patient, and decreasing incredibly the morbidity. If we look at the literature, what we can see? We can see that we have some results that tell us that probably the use of collagen matrix is better than only to apply a coronally advanced flap, but is give worse result in comparison with the cuff plus the connective tissue graft. But the literature doesn't tell us the rule, doesn't tell us when we can use collagen matrix and when we need to use connective tissue graft. And this is my objective today. I would like to give you some suggestions in order to understand when it's possible to apply the collagen matrix instead of connective tissue graft in order to obtain the same result, meaning complete root coverage, increase in thickness, but reducing the morbidity for our patient. And I would like to discuss with you using this paper that I wrote and is published on Periodontology 2000 that represent a decision making in root coverage procedure for the aesthetic outcome that was written in order to give surgeon a decision making process to decide the right surgery, analyzing different anatomic conditions. The first anatomic condition that we need to analyze is represented by non-carious cervical lesion. All of you know that in our daily practice, this clinical scenario is very common, which is the etiological factor that causes gingival recession. Gingival recession occurs for a traumatic toothbrushing technique. That means that 90% of gingival recession are associated with non-carious cervical lesion, and non-carious cervical lesion can be related to the root and can be root abrasion, can involve both crown and root, and can be more deep or more shallow, but should be treated in combination with mucogingival surgery in order to obtain a final aesthetic result for our patient, recreating the physiological anatomy of the tooth and the dentogingival union. And this is what we published in 2011 in order to give a decision making to suggest the combined treatment for non-carious cervical lesion and gingival recession. And the main objective in the treatment of these problems that involve both hard and soft tissues is to treat first the hard tissue, meaning to restore the lost cement-enamel junction. And then, once the cement-enamel junction is properly restored through a restorative therapy, a mucogingival surgery can be applied. So first, what is of paramount importance is to understand where we have to restore the cement-enamel junction once we lost it. And this is the case. If you look on the profile picture, which is the most important pictures to evaluate the loss of hard tissue, we can see this horizontal line. And if we consider this horizontal line as the cement-enamel junction, and we look the dimension of the anatomical papilla that we have that should give us the blood supply for the coronally advanced flap, we immediately understand that this papilla is not enough to give the right blood supply. So we have to look to the cement-enamel junction on the lateral incisor. And if you look the height of the clinical crown of the lateral incisor, you immediately realize, if you want to obtain a final aesthetic outcome, that if the horizontal line represents the cement-enamel junction of the canine, at the end you will not obtain an aesthetic result, because from an aesthetical point of view, a pleasant smile is a smile where the length of the canine, of the cuspid, is higher with respect to the lateral incisor. So probably, aesthetically, we should rebuild, we should consider the cement-enamel junction at a different level. And if you look now at this clinical picture, if we rebuild the cement-enamel junction at this aesthetically guided root coverage level, and we analyze the dimension of the new papilla, I can tell you that this papilla can give us the right blood supply to our coronally advanced flap. So in this case, we can now coronally advance the flap above the new restored cemento-enamel junction. And with the sling suture, we can tightly adapt the gingival margin above the new restored convexity of the clinical crown, giving a primary intention closure that will ensure the stability of our blood clot under the coronally advanced flap. And if you want increase soft tissue thickness, and if we want compensate the root abrasion, the concavity, in order to avoid the risk of flap collapse inside the root concavity, we can add a collagen matrix that will help the flap will reduce the risk of flap collapse and will increase the thickness with time, as you can see, 1 year after the surgery and 3 years after the surgery, where you can see that the complete root coverage was achieved. And complete root coverage means root coverage obtained at the predetermined level, where we restore in a biologically, aesthetically guided position our cemento enamel junction. And thanks to the adjunctive use of the collagen matrix, we were able to obtain also with time a soft tissue increase. And this is of paramount importance in order to reduce the risk of recurrence of the gingival recession with time. And this is the picture showing you the complete case 1 year after the surgery. And if you look from this side, you can see exactly what I told you and explained you before, that thanks to the recreation of the physiological convexity of the clinical crown through the composite restoration, we are able to coronally advance the flap and tightly adapt the gingival margin above the convexity of the clinical crown, and adding the collagen matrix inside the root concavity, we are able to increase soft tissue thickness with time, because the collagen matrix represents a scaffold that will incorporate the blood clot that will remain stable above the root, and with time will become mature connective tissue, able to increase the thickness exactly 1, 2, 3 millimeters more apical with the gingival margin, where we need more thickness in order to reduce the risk of gingival recession recurrence. And as you can see here, we have the long-term result after 3 years, showing you the stability of the coronally advanced flap with time. So first anatomic condition that we need to evaluate is at the level of the hard tissue. Then we have to evaluate the interdental callus. And today I'm not going to discuss with you about the treatment of Miller class 3 gingival recession, because it's not the topic of today. And then we have to evaluate the buccal position of the tooth that we are going to treat, and in presence of a small buccal malposition, we can go at the evaluation of the most important anatomic aspect in the treatment of gingival recession, that is represented by the amount of keratinized tissue that we have apical to the gingival recession. If we have at least 1 millimeter of keratinized tissue apical to the gingival recession, we know that our flap, our coronally advanced flap, can remain stable in the final position, ensuring the possibility to obtain complete root coverage. So in this case, where we have enough keratinized tissue, like in the presented case, where you can see we have 1-2 millimeters of keratinized tissue, we can trust in the coronally advanced flap to obtain complete root coverage. But if we want to increase the soft tissue thickness with time, instead of harvesting a connective tissue graft from the palate, we can add a collagen matrix that will increase. Incorporating the blood clot will ensure you the possibility to increase the soft tissue thickness with time. But in order to obtain this final result, we need to perform the surgical technique in the proper way. So I want to explain you how to perform the coronally advanced flap trapezoidal shape flap design for the treatment of single gingival recession. First things is to measure the gingival recession plus 1 millimeter. This dimension should be positioned starting from the tip of mesial and distal anatomical papilla, and at this level 2-3 millimeters horizontal incision should be traced, and at the end of this 2-3 millimeter horizontal incision, 2 vertical releasing incisions that will reach alveolar mucosa. Why we should measure the gingival recession plus 1 millimeter and at this level starting from the tip of the papilla performing the 2 horizontal incisions? Because this distance represents the distance that the gingival margin should perform in coronal direction. So this distance represents the coronally advanced flap that we need in order to obtain complete root coverage, because at the end of the surgery we want that the gingival margin is 1 millimeter more coronal with respect to the cemento enamel junction. Then flap elevation should be done in a split thickness way at the level of the anatomical papilla, and then full thickness in the central portion of the flap. We need to reach full thickness the bone crest and then overcome it for 2-3 millimeters. And then we connect the vertical releasing incision with the central portion of the flap split thickness. And then, in order to allow the coronary advancement of the flap, we need to perform the so-called deep split thickness incision and the superficial split thickness incision that will allow the coronary advancement of the flap. But let's go on the surgical video to see exactly the procedure. You see, we have the right amount of keratinized tissue, so we can perform a coronary advanced flap that itself will remain stable in the final position, but in order to obtain an increase in soft tissue that is of paramount importance to avoid recurrence with time, we can use a collagen matrix. Before starting the surgery, it's better to open mucoderm and put the mucoderm into the saline, because we want to trim and to fix it when it is already completely wet. Then we can start with our flap design. Flap design means to perform only a bleeding line with the tip of our blade. I measure the recession plus 1 millimeter and I place the same dimension starting from the tip of distal and mesial anatomical papilla. And at this level, I can place my horizontal incision, 3 millimeters length, and at the end of this 3 millimeter horizontal incision, I can place the 2 vertical releasing incisions until I reach the alveolar mucosa. And now it's time to elevate split thickness the surgical papilla. I start elevating the tip of the surgical papilla, and once the tip is identified and elevated, the second tip is identified and elevated, and now they can be connected, trying to maintain as much as possible a uniform thickness in the entire body of the surgical papilla. Surgical papilla should be elevated split thickness until the imaginary line that connects the sulcus with the vertical releasing incision. In this way, we are able to elevate a split thickness surgical papilla of trapezoidal shape flap design. These papilla are wide, are big, are very easy to handle, and since are elevated split thickness, once we will place them above the anatomic desepithelialized papilla, they will immediately have an anastomosis and they will remain stable in the final coronal position thanks to the exchange in the vascular supply between the connective tissue and the inner aspect of the split thickness papilla and the connective tissue of the anatomic disepithelialized papilla. You can see during split thickness elevation until the imaginary line that connects the sulcus with the vertical releasing incision, the blade is maintained parallel to the bone, parallel to the deep surface. And now we have to elevate this central portion of the flap with the periosteum elevator in order to maintain as much as possible the thickness in this central portion of the flap that will be moved in a coronal position and will cover the avascular root surface. So exactly in this central portion of the flap, we want to maintain as much as possible the thickness and the vascularization in the flap. So we want to maintain in the flap the periosteum in this central portion. While in the lateral area of the flap, we want to connect the vertical releasing in split thickness incision with the central portion, maintaining the blade very, very beveled. And this is the deep split thickness incision that will allow to detach the muscles from the periosteum. And this is the superficial one that will detach, as you can see in the schematic drawing, that allow you to detach the muscles from the flap. So now the flap is without any muscle insertion. As you can see, you have to work very, very superficial with your blade, checking the blade by the external, by transparency, because you are removing all muscle insertion from your flap. And now the flap is made only of what? Only of alveolar mucosa, which is rich in elastic fiber and can be pulled in advance, can be coronally advanced as you like, without any tension. And now it's time to do the root instrumentation. Root instrumentation is performed mechanically by means of mini curette until you feel the root surface hard, smooth and clean. And then you can apply EDTA gel for 2 minutes in order to remove the smear layer from the dentin tubuli and in order to expose the collagen component from the dentin tubuli that will be linked with the fibrin net of the blood clot. And then, especially in presence of buccally malpositioned tooth or very wide gingival recession, you can apply amelogenin in order to improve the quality of the connective tissue attachment on the root. And now it's time to trim the mucoderm that was inside the saline, and now it's very easy to enter. As you can see, I prefer to trim the mucoderm with the use of a new blade in order to be sure to be able to cut exactly of the right dimension. The matrix is very easy, and you see the thickness of the matrix is around 1.5. Now it's time to disepithelize anatomic papilla, starting with the tip of the blade inserted at the level of the 3 mm horizontal incision and maintaining the blade parallel to the external tissue in order to remove just a very thin layer of epithelium, trying to maintain as much as possible the underlying connective tissue that will represent the vascular supply for the coronally advanced flap. And using the microsurgical scissor, you are able to complete the disepithelialization under the contact point. And this is the dimension of the matrix. As you can see, the matrix should be placed inside the 2 vertical releasing incisions because you don't want to leave any portion of the matrix exposed at the level of the cemento enamel junction. So you fix the matrix with single interrupted suture using a 7-0 PGA suture exactly at the level of the cemento enamel junction. And you can see the adaptation of the matrix above the root. And now you can close the flap starting at the level of the vertical releasing incision with a single interrupted suture in an apical coronal direction, maintaining the flap with the tweezers in the final position. Thanks to the fixation of the vertical releasing incision, first, you will reduce the tension of the flap, and you will obtain a flap which is in the final coronal position without any tension at the time of the final most important suture, which is the sling suture, that will allow the adaptation of the surgical papilla above the anatomic disepithelialized papilla. What is really important during the fixation of the vertical releasing incision is to maintain with the tweezers the flap in the final desired coronally advanced position in order to gradually reduce the tension. And as you can see now, the flap is in the final position only thanks to the closure of the vertical releasing incision. And this is the sling suture, perforating from vestibular to palatal in one shot surgical and anatomical papilla. Then you turn around with the needle, you pass under the second papilla in one shot. Again, you are in pass around the point and you close the knot in the first papilla where you start the suture. And when you tie the knot, you can see the adaptation of the surgical papilla above the anatomic papilla and the perfect adaptation of the gingival margin around the convexity of the crown. And as you can see at the end of the surgery, you cannot appreciate any bleeding. That means that you are stability of the blood clot under the coronally advanced flap. And this is immediately after 2 weeks, immediately after suture removal, where you can see complete root coverage was achieved. But this is not enough. We want to obtain complete root coverage along with soft tissue thickness increase, because in order to reduce the risk of recurrence with time, we need to have a thicker amount of soft tissue that will withstand a traumatic tooth brushing that can again happen in the future if the patient is not very complaint. And this is the comparison between the before and after, where you can see complete root coverage and an optimal aesthetic result from both patient and professionals' point of view. And this is again the profile showing you the increase in the soft tissue thickness that we were able to obtain thanks to the mucoderm that was able to incorporate blood clot above the root that during time became mature connective tissue graft. And I will just come back 1 second regarding the buccal malposition. This is the only real contraindication for the use of the matrix when you have such a buccal malposition lower incisor. In these cases, we cannot use the mucoderm or the collagen matrix, because in this case we need to ensure the stabilization of the coronally advanced flap in the right position, because in the treatment of gingival recession, a lower incisor, the technique of the coronally advanced flap is a modified technique, modified in relation to the poor anatomic condition that we have to face in the lower incisor. So when we are treating this deep gingival recession without keratinized tissue in the lower incisor under our coronally advanced flap, we need to place a connective tissue that will help the flap to remain in the coronal position and that will act as a barrier to reduce the risk of muscle reinsertion and will allow to recreate the vestibular depth in this very challenging area that is the area of the lower incisor. And what about the treatment of multiple gingival recession? If we want to treat multiple gingival recession, we need to follow the same pathway. We need to follow the same decision making. We have to look if there is the necessity to in presence of non-carious cervical lesion, and we need to evaluate if there is some interdental callus. We need to evaluate in the profile picture if we have some buccal malposition, and we already know that if the buccal malposition is not excessive, we can use the collagen matrix to help the flap to maintain, to have the possibility to maintain the space for the blood clot thanks to the presence of the collagen matrix above the root. And then we have to check in every single tooth the quantity of the remaining apical keratinized tissue. And when we have enough keratinized tissue, we can just perform a coronally advanced flap. Where we don't have any keratinized tissue at all, we need to place the connective tissue graft that will help you to maintain the flap in the final position. And in the borderline situation, where we have only 1 millimeter of keratinized tissue, we can use the collagen matrix that will help us to obtain the increase in soft tissue thickness, reducing the morbidity for our patient. And which is the technique in the treatment of multiple gingival recession. The technique of choice is an envelope cuff technique that consists of a number of interdental oblique incisions that should be traced, starting measuring the recession of the canine, which is in the middle of the surgical area, which is from central to fourth molar, and this measure should be reported starting from the tip of the mesial and the distal papilla, and then the same thing should be performed measuring the recession at the level of the first premolar, and this measure should be placed on the distal side of the premolar, and the same thing should be done at the level of the second premolar and then at the level of the lateral. And now we can trace this oblique interdental incision starting from the gingival margin of the premolar and directed toward the central axis of the flap that is represented from the canine. And from the mesial aspect, starting from the lateral incisor directed to the canine, because when the flap, the envelope flap move in a coronal direction, we have not only a coronal advancement of the flap, but also a rotation of the surgical papilla, mesial the canine toward mesial and distal the canine toward the distal area. So once the papilla are elevated, split thickness, and then we have the full split thickness as in the treatment of single gingival recession, and then deep and superficial split thickness to obtain the coronal advancement of the flap. We see that our envelope cuff type flap for multiple gingival recession is not only a movement in the coronal direction, but also the papilla rotate toward the mesial aspect, while the papilla distal the canine will rotate toward the distal aspect. And for this reason, we need to trace this interdental oblique incision directed toward the central axis of the flap, which is represented by the canine in this case, where we are going to treat a second sextant from central to premolar. Then after the desepitalization of the anatomical papilla, we will do exactly the same thing that we have seen before for the treatment of single gingival recession. And in this movie, you can see exactly the procedure. This is a false recession that we need to trace at the level of this lateral incisor in order to be able to create this oblique interdental incision that is able to create this triangular shaped papilla that will allow to cover the recession at the level of the canine, because otherwise, if we don't create this false gingival recession we should have performed a too flat incision in this case that doesn't allow to cover the recession at the level of the canine. And as you can see, the other incisions are performed from the gingival margin of the premolar toward the canine, from the gingival margin of the second premolar toward the first premolar, and from the central incisor toward the lateral incisor, creating this triangular shape papilla in this case, not trapezoidal shape as we performed in the that should be elevated split thickness. And at the end of the surgery, you will see that in this case, since the flap is without but is an envelope flap type, you will see that the papilla will not move only coronal but will rotate distal, measure in this case, measure to the canine and toward the distal area, distal the canine. This is the split thickness elevation of the surgical papilla that should end at the level of this imaginary line that connect the sulcus of the two adjacent teeth, exactly as we did in the treatment of single gingival recession. This is the imaginary line that connects the sulcus of the adjacent teeth, and this is exactly the level where we should stop our split thickness of the triangular shape papilla. The shape to keep intact the delicate vertex of this triangular papilla and trying to maintain as much as possible a uniform thickness in the entire body of the papilla, maintaining the blade parallel to the bone. And now we have to elevate full thickness with the periosteum elevator until we reach the bone crest, and then we overcome it for 1-3 millimeter in order to incorporate the periosteum inside the flap in this portion of the flap that will be moved coronal and will cover the avascular root surface. And now with the deep split thickness incision, we are going to detach from the periosteum. You can see the blade is now maintained parallel to the bone, detaching the muscles from the periosteum. You can see muscles from the periosteum. Thus allow, once the muscles are detached from the periosteum, to change the position of the blade that can be maintained parallel to the external surface to detach the muscles from the flap. But we need to first detach the muscles from the periosteum. When we need to go beyond the mucogingival line with the deep split thickness incision to detach completely the muscles from the periosteum. Now you can see with the probe that we are able, after the separation of the muscle from the deep aspect, we are able to change the inclination of the blade that now can be maintained parallel to the external surface, parallel to the flap. And with this movement, very, very superficial, checking the blade by transparency, we completely remove all muscle insertion from our flap. And the flap will remain completely free from the muscles and can be coronally advanced without any tension. This is the way to coronally advance the flap, tunnelizing the central incisor papilla. So we need to extend our deep and superficial split thickness incision beyond the central incisor papilla in order to allow the rotation of the papilla between the central and the lateral. So we need to extend the deep and the superficial beyond the interincisor papilla, and more distal with respect to the first molar in order to allow the rotation of the papilla between the premolar and the first molar to obtain the complete root coverage also of the molar. And this is the root instrumentation performed exactly in the same way with the use of the Mini 5 curette until the root surface is hard and smooth, and then we can apply the gel, EDTA gel, in order to remove the smear. After 2 minutes, we can rinse abundantly with saline, and we can apply amelogenin in order to improve the connective tissue attachment, the quality of the connective tissue attachment. And now, since at the level of the canine and of the premolar, at the baseline, we evaluated that we have enough keratinized tissue to obtain a stability of the flap, so we don't need to add a connective tissue graft. But since we are at the level of the more buccal tooth, that is represented by the canine, we want to increase the thickness with time in order to reduce the risk of recurrence, and we want to keep as much as possible the space between the flap and the buccal root of the canine and of the premolar. So we add the mucoderm that was trimmed in order to be placed at the level of the cemento-enamel junction of both canine and premolar after the desepithelialization of the anatomical papilla with the blade and the microsurgical scissor at the level of the interdental contact point. And this is the mucoderm that is placed at the level of the cemento-enamel junction at the base of the desepithelialized anatomic papilla, fixed with a 7-0 PGA single interrupted suture. And the height of the mucoderm is a distance from the cemento-enamel junction to 2-3 millimeters above the bone crest, because we want to place the matrix above the bone crest in order to use the step that there is between the bone crest and the root to improve the space from the blood clot in the inner aspect of the matrix between the matrix and the root. And this is the flap closure. Flap envelope, cuff envelope type flap is closed with the sling suture performed exactly in the same way that we saw before for the single gingival recession. In this case, we don't need to close vertical releasing incision because we don't have vertical releasing incision. So we start closing the flap on the more distal aspect because we want to reduce as much as possible the tension for the last most important suture at the level of the canine. We want to see the complete closure of the flap without any bleeding, and we want to completely cover the matrix. We don't want to leave any portion of the matrix exposed, because if the matrix remain exposed, it will be lost during the immediate post-operative period. While if you completely cover and protect the matrix with your flap, that will be able to incorporate the blood clot and become soft tissue thickness with time. And as you can see in this picture, at 1 year and after 4 years, we were able to obtain complete root coverage in all treated teeth, and we were able to obtain a soft tissue thickness increase, especially at the level of the canine and the premolar, where we added the mucoderm. And what about implant? In the treatment of implant, we recently submitted a new classification that is based on the position of implant supported crown and the implant head, and it is based on the papilla dimension, mesial and distal, the implant supported crown. And in this classification, we have 4 classes. In the first class, we don't have a real soft tissue dehiscence, meaning that at the level of the implant-supported crown, the gingival margin is in the correct, ideally aesthetic position, meaning at the same level of the homologous lateral or contralateral tooth. But if you look on the occlusal aspect, you can see that there is no deficiency in apicocoronal dimension, but there is a buccal lingual dimension. In the class 2, we have an apical shift of the gingival margin with respect to the adjacent tissue, but if we look at the crown of the implant supportant, or the crown of the implant is inside the imaginary line that connect the tissue on the adjacent teeth. In class 3, soft tissue dehiscence, we have a soft tissue dehiscence, meaning an apical position of the gingival margin with respect to the ideal position. And if we look occlusally at the crown of the implant supported crown, we can see that the crown is outside the imaginary line that connect the soft tissue at the level of the two adjacent teeth. So we need to remove the crown and to check if the implant head is inside or outside this straight line. And in class 3, the implant head is positioned properly. That means is more palatal with respect of the straight line that connect the adjacent teeth. While in class 4, if we have to remove the crown because the crown is outside, and also the implant head is outside. And we have to check also what is about the papilla adjacent to the implant supported crown. And in subclass A, we have a good amount of papilla, meaning that mesial and distal papilla are both bigger than 3 mm, that will ensure a good blood supply for our coronally advanced flap. While in class B, at least one papilla is less than 3 mm in height. And in class 3, we have this terrible situation with no papilla at all on the distal aspect. So in the treatment of this kind of deficiency around implant, what I can tell you is my experience is that Mucoderm works very well in the treatment of class 1 deficiency, meaning in the class where you don't have an apicocoronal displacement of the gingival margin, but in this case where you have a buccal lingual deficiency and you want to increase the soft tissue thickness in order to give a proper emergence profile of the crown, and you want to increase the soft tissue in order to prevent the risk of recurrence and in order to avoid the risk of transparency of the underlying abutment. And in order to obtain better soft tissue thickness, in this case you can change the crown and let the soft tissue mature with time before the surgery to have better surgical papilla that will be desepithelialized during the surgical procedure that consists of the same trapezoidal shaped flap design that we saw before for the treatment of gingival recession, and thanks with the use of this thicker Mucoderm that is treated maintaining more thick the central portion and reducing the peripheral aspect where we are going to fix the matrix in order to increase the thickness of the soft tissue around this implant to improve the emergence profile of the crown, to improve the aesthetic for our patient, and to reduce the risk of recession with time. You can see the Mucoderm in this case is thicker with respect to the one that I use for the treatment of gingival recession around teeth, but is on the same time is very, very easy to handle. The same fixation that you see before with single interrupted anatomical papilla, and then the flap is coronally advanced and closed exactly as we see before in the treatment of gingival recession. And this is at the time of suture removal, and you can see during the soft tissue maturation after 6 months the soft tissue, and after 6 months you can see that the baseline concavity is now a physiological convexity, exactly as if you have a root and not an implant in this area. And after 9 months you can replace the definitive restoration, ensuring the aesthetical result and the aesthetic result that can be maintained for 2 years. And this is the comparison between the baseline and the 2 year. So let me just tell you that you have to use the collagen matrix as much as possible instead of the connective tissue graft in order to reduce the morbidity for your patient. When you are treating gingival recession, you can apply the mucoderm when you have at least 1 millimeter of keratinized tissue in your flap and in presence of moderate buccal root prominence and in presence of the root abrasion, because the matrix will avoid the flap collapse above the root. Promising result has been obtained in the soft tissue increase with the matrix deficiencies. And if you have some question, I'm now happy to answer you, and I'm now trying to read your question, and one question is regarding the type of blade, and I usually prefer 15C blade. You can use also some micro blade, but the 15C blade for me is the right blade to perform this kind of surgery. I'm glad you like the webinar, and I hope to have the chance in another webinar to show you some more results in the treatment, especially of soft tissue dehiscencies around the implant. And what I can tell you is also that there is a question: how can differentiate between Miller class 2, 8 and B gingival recession? What in Miller class 2, the problem is that in Miller class 2, according to the definition of Miller, you are speaking about gingival recession with no keratinized tissue at all. In my opinion, there are some differentiation between class 2A and class 2B, because in class 2A there is still 1 millimeter of keratinized tissue remaining apical to the gingival recession. And in this case, for me, it's better to use the connective tissue instead of the metric, because most of time this 1 millimeter of keratinized tissue is probable. So you need to have 1 millimeter of keratinized tissue, which is not probable. So in these cases, I prefer to add connective tissue graft. Yes, I think that mucoderm now at that moment is helpful to increase soft tissue stability, to increase soft tissue. If you don't have the stability of the flap because you don't have any keratinized tissue at all, you still need to use the connective tissue graft, because you need something that will maintain the flap in the final position. And at the moment, the only material that really help the flap to remain stable is the connective tissue graft. But mucoderm gives very promising and good result in increases soft tissue thickness. I use PGA suture, and I use 7-0 PGA suture to fix the matrix and to close the vertical releasing incision in the treatment of single gingival recession, while for the sling suture I use the 6-0 PGA, and I always remove the suture after 2 weeks, despite PGA is resorbable. After 2 weeks, I recall the patient and I remove the suture in order to avoid plaque accumulation. And since after 2 weeks, they start not to have the right function and tension. And after 2 weeks is the right time to remove the suture without causing any trauma to the soft tissues during the removal of the suture. The needle of the 70 is the 8mm needle, very short, that is very easy to use, especially when you are fixing the matrix at the base of the anatomic disepithelialized papilla. One question: if there are two incisions, between which layer of tissue is the graft? No, the graft and the collagen matrix should be placed above the root and above the bone crest, which has been exposed to the full thickness exposure in the central portion. The two incisions that are the deep split thickness incision and the superficial split thickness incision are more apical with respect of the position of the matrix. The matrix is placed at the level of the cemento enamel junction and reach the bone crest. Then the other two incisions are more apical and are performed in order to obtain the corneal advancement of the flap. Another question is, which is my attitude if I have to treat soft tissue dehiscence around implant. If I have a soft tissue dehiscence around implant, maybe in another webinar, or if we will have the occasion to see each other in a congress, I will tell you my combined prosthetic and surgical approach that consists of a pre-surgical prosthetic approach plus a bilaminar technique with a trapezoidal shape flap design plus connective tissue graft in the treatment of soft tissue dehiscence in apicocoronal around implant. And in presence of this kind of soft tissue dehiscence, if there are some thread of the implant exposed, I usually, which were not contaminated, I usually clean it with a chemical decontamination. While if there is some contamination, I use some titanium microbrush in order to very well clean the surface of the thread that were exposed to the oral cavity. But the treatment of soft tissue dehiscence around the implant is another very big and complex topic that will need at least 3 hours of webinar in order to help you and really to tell you which is my treatment plan in these cases. So regarding the implant treatment, I can suggest you the use of the collagen matrix when you have to increase the thickness. So in the cases where you don't have an apical coronal displacement of the gingival margin around the implant, but in the cases where you have a concavity, where you need to increase the soft tissue thickness to restore a correct crown emergence profile. Okay, so I think if there are no more questions, so probably we can close the connection. And I want to thank all of you for listening my speech. And I hope to have the chance to meet you personally in the future. And good luck for the treatment of your gingival recession or soft tissue deficiencies around implant. Bye. Have a nice evening.